everybody hear me okay? All right, cool. So first off, I want to immensely thank Cindy for this opportunity. I'm so honored and thrilled and excited to be talking to you guys today, especially as the first rehab person you've had at Trauma Corps. You know, we always say that in the rehab world that, you know, you guys here at Children's, you add years to life, you save people's lives, and we add life to years. So we help people after trauma, injury, illness get back to what their real life looks like. So I'm Melissa Fleming. I'm one of the pediatric rehab docs here at Children's. I wear a lot of different hats. I mostly do consults here, so I'm seeing kids all over the hospital, right? So the NICU, the PICU, the fifth floor. We spend a lot of time on the fifth floor between neuro and trauma and ortho. Everywhere. We go everywhere in the hospital. I also help run the acute inpatient rehab unit over at the National Rehab Hospital for the pediatric unit. And then I also do a bunch of different clinics here as well. So I do a lot. Today we're going to be spending a lot of time talking about what is rehab, right? So who are the people that make up a rehab team? When should they be involved? How can they help you, you know, to get your patients what they need? We'll talk about different levels of post-hospitalization rehab care and specific resources in the DC area, right? My goal today is to make this incredibly practical, like real life, you know, advice and guidance on what does rehab look like in DC for a kid who's, you know, dealing with injury, illness, trauma. And then at the end of the talk, we'll talk specifically about pediatric traumatic brain injury. You know, obviously Dr. Maceras did a wonderful job talking about issues in pediatric traumatic brain injury, but we'll really focus on some of the outcome measures we use, particularly the Rancho Los Amigos scale. That's a very specific rehab scale that maybe you guys are less familiar with. This is a judgment-free zone. There's no such thing as a dumb question. Hopefully we'll have time for questions at the end. If not, please put it in the chat. I'm happy to follow up with you folks by email. If you have additional questions, like please ask questions as we're going. You know, I realize rehab, in some ways it's a lot of common sense, but it also uses somewhat esoteric language, right? It's kind of its own language. So if things aren't making sense, please by all means speak out. I wanted to start with just a little bit of a funny clip. I think one of the really unfortunate things about PM&R, physical medicine and rehabilitation, is it's not well understood even by other medical folks, right? It's kind of its own little unique field. So it's just like a funny little, do you guys know Dr. Glaucom? Yeah, on YouTube. Yeah, he does these like hilarious skits. So we'll just play this real quick. If I can get it to play. Oop, oop. Sorry, 1 second. Oop. Okay, we'll watch it that way. Oh no, the sound's off. Sure. Oh, is Cindy not in the room? I don't know how to put the sound on. Hold on, sorry, 1 second. Yeah, let me just pause it. Sorry, guys. Oh.
Hi, I'm a new med student.
Oh, you're a med student. Okay. Very funny. You got me.
No, really, I'm a med student.
What?
Well, we don't get med students. Welcome, come in. What made you want to do this rotation? Well, I've always been interested in mental health. Oh, okay, I get it. You know I'm a physiatrist, right? Not a psychiatrist. This is a PM&R rotation. Yeah, I know. Okay. What interests you about PM&R? The P? What does the P stand for? Protein? Protein. You think I practice protein medicine?
Hey, Doc, I have a bag of thank you notes from your patients. Do you want me to bring it in?
Yeah, put it with the others. By the way, it's physical medicine and rehabilitation, and patients will love us.
Yeah, and that's accurate. No one knows what we are, but patients love us. So physical medicine and rehabilitation, again, PM and R, it's an ampersand. We are not PM&R. When I see that in the note, I know someone doesn't know what I do. So typically when I introduce myself to families, I'll explain, you know, hi, my name is Melissa Fleming. I'm a doctor in physical medicine and rehabilitation. People say PM&R for short, or just plain old rehab. People have a sense of what rehab means. Again, PM&R folks are typically MDs or DOs, right? We are physicians. We went to med school, but then we went to a PM&R residency and potentially a fellowship afterwards myself. So I did a PM&R residency, which is largely with adults, with rotations in traumatic brain injury, spinal cord injury, amputations, all kinds of, you know, different rehab care for neuromuscular and musculoskeletal issues. And then I did a 2-year pediatric fellowship on top of that. So I'm not a pediatrician. That is not my background. I don't look in kids' ears. I'm just a rehab doc. The other name for this field is physiatry, which sounds super fake, so I tend not to use that word, but you can also say physiatry doctor or physiatrist, and that comes from the Greek words for physical and art of healing. We are not psychiatrists. Okay. Don't want to belabor this, but just really briefly, PM&R as a field really developed after World War I. You had all these returning veterans with all sorts of new impairments and disabilities, and we needed folks to figure out how to help them. So first signs of the field were really after World War I. First residency program was up at Mayo in Rochester in 1930s. In the 1940s and 50s is really when PM&R as a field blossomed, because once again, we had returning veterans from World War II with all sorts of new injuries, disabilities, and then the polio epidemic as well. You really saw kind of a blossoming of PM&R physicians taking care of those folks. It became a board-certified specialty in 1947. When it comes to PM&R in general, again, most PM&R docs treat adults. There's more than 10,000 of us in the U.S., so not that rare or uncommon. But for pediatric rehab docs like myself, there's only about 300 of us in the whole country, in the whole U.S. And 6 of us are here at Children's. So 2% of all the peds rehab docs in the country are here at Children's National. So again, my name is Melissa Fleming. Most of you probably know my chief, Dr. Burton. This is Dr. Rabin, who's been here a long time as well, Dr. Morozova, Dr. Miran Shin, and Dr. Tom Chang. Dr. Chang is typically in Fairfax, so not really here in DC very much, but all the other partners do see patients here in DC. Myself and Dr. Burton are the 2 docs who, again, we have a contract with National Rehabilitation where we run their pediatric unit. Again, NRH is mostly adults, but they have a specialized peds unit. So myself and Dr. Burton are the 2 docs who rotate through there. And he and I also do a lot of consults here. So we're probably the 2 faces you might be most familiar with. When we think about what does a pediatric rehab doc do, a lot of what we do is setting goals, right? Having very honest, frank, deep conversations with families. When we know a child's diagnosis and prognosis, what is realistic in terms of what we can achieve for function, right? So that's a huge part of what we're doing is setting attainable functional goals. We always want to look to maximize independence with mobility and ADLs, right? Independence is the most important thing for kids, right? Kids need to learn how to do things on their own. No kid wants to be pushed dependently in a wheelchair by their parent, right? So even if for whatever reason, it's not realistic that you'll regain walking, we still need to come up with a way for you to independently move around in the community and take care of yourself. Preventing medical complications due to disability. And again, I want to emphasize one more time, knowing the diagnosis and prognosis is essential to making a reasonable rehab plan of care. Unfortunately, not uncommonly, I'll be consulted by, neurology or hospitalists. Hey, we have a kid who, can't walk. Cool, what's the diagnosis? We don't know, we've done a workup, we don't have an answer. Can they go to rehab? And we'll like, well, what goals? What's realistic? What are we going to accomplish? It's very hard to make a rehab plan of care without knowing what is wrong with the child, in other words. I do want to take a minute to kind of talk about this in depth. When I think it's really important when you're working as part of an interdisciplinary team, and rehab is always interdisciplinary, right? There's no one person on the rehab team that's more important than anyone else. The physician, the PT, the OT, the speech therapist, we all have the nurses, we all have to be working as one cohesive team to make a rehab plan of care, work. So I think it's really helpful to when you're working across disciplines. How does my partner from another discipline, how do they approach patients? What is their mental model? Because when you understand that, you can really collaborate in a really meaningful, effective way. So as a peds rehab doc, my model of disability, this is adapted from the World Health Organization's International Classification of Function, ICF, a lot of words. So the way we think about it is, what is the disease, right? So the disease is what's happening on a cellular, molecular level. What impairments come from that disease? So impairments are on a body system level. So things like weakness, contractures, aphasia, dysphagia, dysarthria, whatever the impairment is, right? That's on a system level, so that musculoskeletal system, neurologic system. How does that impact disability? Disability is on the personhood level. And then how does that impact handicaps? Handicaps are on the society level. On the next slide, we'll go through a few examples of how to use that model. But again, disease leads to impairments, leads to disability, leads to handicap. I think this is a really helpful model to use because once you identify the impairments, it lets you really target your interventions appropriately. I'll just give one quick example. I got a new consult request from the hospitalist team. Hey, Johnny's not getting out of bed. Can you come see them? Okay, cool. They can't get out of bed. They're not walking. That's their disability. Let's drive down. What is the impairment? Why are they not getting out of bed? They're depressed. Okay. It is true that folks with depression are not doing their ADLs. They don't want to move. That's not a PM&R thing, right? PT is not going to fix their depression to get them moving. They need psychiatric help, right? So again, once you know what the impairment is driving that disability, you can target your interventions appropriately. We decline that consult, obviously. Here's some examples of how we can use that model. So thinking about Duchenne muscular dystrophy, for example. I mentioned I wear a lot of hats. I do work in the MDA clinic here for kids with neuromuscular disorders. When we think about boys with DMD, right? The disease is they have a faulty gene, right? Their DMD gene makes this non-functional dystrophin protein, which is a protein found on the muscle membranes, right? So because that protein doesn't work right, the muscle membranes are prone to getting broken down, right? So they get weakness over time. So again, the disease is the faulty DMD gene, the faulty dystrophin protein. That's the cellular molecular understanding of their disease. Again, because their muscles don't work, they're weak, right? And weakness leads to contractures. Because they can't, range their limbs themselves because they're so weak, those joints over time will get tight. So weakness and contractures are the impairments we see because of the disease. Those impairments, if you're weak and your legs are contracted, you can't walk, right? We know boys with Duchenne will typically lose ambulation by 12 years old. So that's the disability. Their loss of ambulation is their disability. And then thinking about that child, on a societal level, if they lost the ability to walk and they live in a townhouse, guess what? Now they can't access their home. They can't get up and down the stairs. Or their school doesn't have a ramp. They can't get into school. So accessing their home and their school is the handicap. Let's think about stroke as another example. So stroke is a cerebrovascular injury, right? So whether it's a hemorrhagic stroke due to like a ruptured AVM or an ischemic stroke due to a thromboembolic event, the neurons are not getting appropriate vascular supply and they die, right? That's the disease on a cellular molecular level. On an impairment level, on a body system level, because of their injury, they're weak, right? If it's their motor strip, right, they're going to be hemiplegic. They can't eat, right? If their bulbar, system is impacted, they're not able to chew and swallow, right? They have dysphagia. Again, if they're weak here, they can't get words out appropriately. Everything sounds slurred, so they're dysarthric. Maybe, they have a language issue in their brain. They can't think of the words they want to say. They have aphasia. Neglect is where you have, your eyes work, but your brain is ignoring all the sensory and stimuli on one half of the world, right? So you're not paying attention to anything on your left side. You're just looking at the right side of your world. That's visual neglect. Abnormal muscle tone, right? So typically after a stroke, you'll start off hypotonic and floppy, and over time you'll become hypertonic and spastic, right? So all those different impairments you can see after a stroke lead to loss of independence with ADLs, right? Typically if that kid is right-handed and now they have right hemiplegia, they can't brush their teeth, they can't brush their hair, they can't dress themselves, right? So on a personhood level, their disability is that loss of independence with ADLs. And then on a societal level, maybe that was a teenager who was driving before and now they can't drive, right? They lost their use of their good arm, or they need assistance at home and school to bathe, dress, things like that, right? So that's the societal level. As I said before, and I cannot emphasize this enough, rehab is always interdisciplinary. When I'm on service at NRH, at our inpatient rehab unit, I am constantly talking to my PTs, my nurses, my OTs, my speech therapists. Like, we are in constant communication, because if we don't have a shared mental model of what we need to accomplish for that patient, nothing will work, right? So again, I really cannot emphasize enough how interdisciplinary rehab is. Rehab nurses, I know there's no rehab RNs in the room, but they deserve such a special shout out. I think my perception is that, it's thought that rehab nursing is like an easier type of nursing because it's certainly less hectic than the IC or the ED. Obviously, that's certainly true. But rehab nursing is really its own unique, special, wonderful, field within medicine. As a rehab nurse on the inpatient rehab unit, you develop such an intimate bond with your patients and your families. They are going through the worst thing that's ever happened to them in their lives, and you're helping them regain a sense of normalcy. It's like an incredible, incredible thing. The ones that are kind of highlighted in the colors here are the ones we're going to talk about in depth on the next few slides. So the ones that are not highlighted, I'll just quickly say, a neuropsychologist versus a psychologist, just in case folks don't know that terminology. So a psychologist is helping you with feelings, right? So how you're coping with new disease, disability, and behavior management. A neuropsychologist is looking at your thinking skills, your cognition. So a neuropsychologist can do in-depth assessments of a patient's executive function, their attention, their memory, things like that, and help make recommendations to optimize cognitive function. Versus a psychiatrist is someone who does med management for psychiatric disease, right? So differences there. Again, before I move on, one more team member I really want to highlight. So every pediatric inpatient rehab unit, no matter where you are, has an education coordinator as part of their team. When we're thinking about disability from injury, illness, or trauma, a child's job is to go to school. So thinking about what that return to school plan looks like, again, every inpatient rehab team has an education coordinator whose whole job it is to come up with a safe, appropriate return to school plan, right? Which we don't have that here at Children's. The oncology services, you guys might know, oncology has, through a grant, they have their own education coordinators to help their kids with cancer get back to school. But on the 5th floor and the 7th floor, it's like a free-for-all. There's nobody whose job it is to help with return to school planning. I wanted to highlight the difference between physical and occupational therapists because it's not always obvious what the differences there are. So one kind of simple way to think about it is if you cut the body in half, just cut the body right through the waist, any skill that primarily involves your lower extremities is going to fall under PT for the most part. So things like, how do they move within the bed? Can they reposition themselves in bed? Can they get out of bed? Can they stand? Can they walk? Can they run? Can they jump? Can they go up and down stairs? What does their balance look like? Are they a fall risk? Those are all things that are going to be under the PT domain. Occupational therapy, again, cutting the body in half this way, anything that's up here. So how we use our hands, right? And we certainly need our hands for activities of daily living. So dressing yourself, getting on off the toilet, things like that. Transfers are something that is, transfers are both, you know, an ADL and a gross motor skill, so transfers fall under both. And certainly here on the, in children's, when PT and OT are consulted, they're both looking at transfers. That's you know, a huge part of what they're doing here because we got to get kids out of bed. In the NICU specifically, our OTs here do feeding therapy. Anywhere else in the hospital, 5th floor, 7th floor, it's going to be speech therapists doing that. But in the NICU specifically for our babies, OT will do feeding. And then occupational therapists, some OTs will also specialize in vision rehab. So again, thinking over at National Rehab, we have a neuro-optometrist who works really closely with our OTs to come up with a schedule for visual exercises, specialized glasses, right, to help them improve their vision. ADLs, I think probably most of you guys know what ADLs are, but just to say really quickly, so activities of daily living, you can think as either being basic versus instrumental, just in case you ever hear this language. So our basic ADLs are all the things you do in the morning from the time you wake up until you leave your house to go to work, right? So you had to get out of bed, you had to dress yourself, you had to eat breakfast, you had to, you know, groom yourself, right, do your hair, brush your teeth, all that kind of stuff. And then instrumental ADLs are all the things you do in your regular life to make your life work. So the ability to go shopping for yourself, to keep up with your housework, make sure your house is clean, get your laundry done, manage your money, balance your checkbook, pay your bills. For kids, keeping track of school assignments, right, that'd be an instrumental ADL. When we think about ADLs, the acronym you hear a lot is death shaft, which I think is weird, but that's one of the ways you can think about what are the ADLs, death shaft. Just to say a little bit more about the differences and frankly similarities between PT and OT, if you have a kid who is either chronologically or developmentally less than a year old, so for example, a 15-year-old with really severe spastic quad CP who is at baseline dependent for their mobility and, you know, their ADLs, right? This is a kid who can't hold their head up on their own. They don't roll, they don't sit, they're dependent on their caregiver for all of that. You don't need both PT and OT seeing that kid. When you're developmentally less than a year old in terms of your skill set, there's so much overlap between what PT and OT do, you can just consult one service, you don't need both. And then for that same population of kids who are chronically dependent for their mobility, you know, if they're in-house with a new, for example, like their status post spinal fusion surgery, right, for their neuromuscular scoliosis or what have you, it's really appropriate for PT to be involved to help figure out what is the best way to transfer that patient. How should they be getting out of bed? Should it be a Hoyer lift? Should it be a 2-person sheet transfer? That kind of thing. And PT will also lend adaptive equipment. If their home wheelchair isn't here, right, if the parent didn't bring it in because they're brought in by ambulance, we can lend you guys like a Rifton chair or, you know, what have you to get them out of bed. But the actual act of getting that patient out of bed, you know, twice a day, every day, you know, that typically will fall to families at the bedside and or to nursing, right? It's not necessarily realistic that PT will be up there twice a day, every day just to get dependent patients out of bed. I think this is something that I wish Children's as like an institution, I wish we had a better systemic solution for this, right? Kids deserve to get out of bed, even if they're dependent. I wish we had a team of folks who just got patients up. Like you know, because nurses have plenty to do as it is, right? It's to have the resources to dependently get a patient up if it takes 2 people. Like it's just hard to fit that in the day, right? So I wish we had a dedicated team that just got patients out of bed. Speech therapists, I think most folks think of speech therapists for feeding, and certainly oral motor skills for feeding is a huge part of their assessments and what they do. There's a few different ways that speech therapists can evaluate for dysphagia. So one is their bedside swallow exam, right? So just with their eyes, with their ears, with their hands, they can look at how's the patient managing when you give them a bolus, right? Like, you know, some chocolate pudding on a spoon. What do they do with that? How long does it take to swallow? What does that look like? Are there changes in their voice or their, you know, are they coughing, things like that? For a more objective measurement of swallow, they can do a FEES, a flexible endoscopic evaluation of swallowing. That's where they go in with a camera and they look at what is happening, with the, you know, the muscles and structures here when the swallow is happening. And then a modified barium swallow is a real-time X-ray, right, where they're eating a cookie or whatever that's dipped in a radiopaque material, so you can see in real time with an X-ray where is it going when they swallow. Speech is not just feeding, though. So speech also looks at communication. When we think about communication, we divide it into speech versus language, and those are 2 different things. So speech is this. Speech is the muscles here and how they coordinate getting the words out. So if you're speaking, but it sounds slurred or it's soft or things like that, that's a dysarthria problem, right? That's a bulbar problem. versus language is a brain, right? Your brain thinks in English and puts grammatical structures together to communicate what you want to say, and when those skills are lost, that's an aphasia, right? So language is up here, speech is here, speech therapists do both. And then lastly, cognition. I think this is something that is at times overlooked, but our speech therapists are capable of doing a cognitive assessment as well. Especially with our traumatic brain injury folks, right? Like they might be good enough to talk to you, right, to answer basic questions, but we certainly get worried about higher level cognitive skills, right? Executive function, problem solving. Speech therapists can look at that. It is really important for our trainees when they're putting orders in. You're putting a speech therapy order in, or really any therapy, PTOT, whatever it is, just be clear on what you're asking for. Sometimes, folks will have a very obvious communication or cognitive deficit, but because the order asks for a feeding eval, the speech therapist is required to do a feeding eval. They have to answer what's on the order. So just be clear about what you're looking for when you consult therapy. We don't have a recreation therapy department here at Children's, but again, this is a very common member of a rehab team. So for example, at the National Rehab Hospital, we have an excellent therapeutic recreation department, TR for short. These are therapists, right? They went to school for training for this. They are therapists. And recreation therapy focuses on socializing skills. So they can use arts and crafts, animals. I know pet therapy here I think is under child life, but again, in a rehab setting, it would be under TR. Sports, games, dance movement, drama, music, community outings. So again, our music therapists are under TR at NRH. Sports, we have an incredible adaptive sports program through the National Rehabilitation Hospital. So as one of the TRs I work with who I love has said, any game can be adapted, right? Any recreational thing can be adapted to meet any level of ability. In the DC area, you guys might know the Fairfax Falcons. That's probably the best known adaptive sports team. They're a wheelchair basketball team out of Fairfax, but there's plenty of other ones. So if you are a wheelchair user, sports is still an option for you. And the community outings are the best. Everybody loves community outings. Again, when we're in rehab, we're trying to set our patients up for success when they go home. So community reintegration is a huge part of what we're looking at, and our TRs help with community outings for that. Assistive technology professional and ATP, this is something that might be a new concept for folks here because we don't have ATPs here at Children's. Like you're not going to interact with an ATP anywhere in this building because we don't have them. An ATP is somebody who really specializes in knowing what sort of adaptive equipment is most appropriate for a patient. Within the heading of ATP, there's a subspecialty certification in a seating and mobility specialist. So that's someone who really can identify exactly what features of a wheelchair is needed for that particular patient and what they need, as well as a rehab engineering technologist, right? So they're folks who help with making all sorts of adaptations to a home environment or what have you to maximize function. DME is probably a term you guys are familiar with, durable medical equipment. So that can include a whole lot of things, right? So canes, crutches, walkers, any sort of a mobility device, hospital beds, lift systems. We use the word Hoyer pretty interchangeably. A Hoyer is a specific brand. It's like saying Scotch tape, right? There's other types of tape, but we say Scotch tape. So Hoyer is any sort of a lift system, Hoyer being one brand. All sorts of bathroom DME, so having a commode, a raised toilet seat, shower chair, tub transfer bench, a wheeled mobility device, so that could be a manual wheelchair, right, with like big wheels that you're using your arms to push, a power wheelchair, and there's all sorts of ways that you can do powered mobility where, you're using a joystick or head controls to drive your car, an adaptive stroller if the patient is young enough and it's developmentally appropriate to be in a stroller setting. Car seats are a major issue. Again, systemically, Children's doesn't really have a great solution for car seats for kids with new injury, illness, or trauma, new disability, who might need an adaptive car seat that didn't have one before. There's no one here at Children's who's a certified car seat tech, as far as I'm aware. Certainly not in the rehab department. We don't have anybody who's a certified car seat technician. And we also don't have a way to obtain car seats very easily, right? So something that, again, on a systemic level has not really been figured out yet. When it comes to obtaining DME, you can own it, right? You can go through your insurance to have it purchased for you. You can rent it if you have what you know is going to be a very temporary disability. Great example, a typical kid who breaks their leg and is going to be in a cast for the next 6 weeks, but when that cast comes off, they're expected to resume being able to walk. You would just rent a wheelchair for those 6 weeks. There's no sense buying one. And then borrowing one, particularly for our uninsured kids who don't have the ability to get DME through their insurance, because they don't have insurance, you can go through loaner closets, like different charities are set up to help kids get equipment if they need it. So again, thinking about options to get that. So Children's does not have its own DME clinic. I think people are always surprised to learn that because Children's has so many things, but we do not have a wheelchair seating clinic, DME clinic here. So again, obtaining DME on discharge for patients is not it's not a super well coordinated process. When folks have DME already, so for example, the kid comes in with their own wheelchair from home, but that wheelchair needs repairs, it's in a state of disrepair, that's really tricky. The therapists here always want to help, right? All the therapists who work here are like kind-hearted, well-intentioned people, but it's really not appropriate for our therapists to make repairs to a wheelchair, right? Because again, even if they have the best of intentions, if they futz things up, you've now voided the warranty and the vendor won't repair it anymore. So anything mechanical can break, as you guys well know, right? If you drive a car, if that check engine light comes on, you got to go take it to the mechanic. Same idea here. If your wheelchair is in a state of disrepair, mom and dad need to call the vendor and have the vendor fix it. That's the most appropriate way to fix wheelchairs. Another thing to say is in terms of, again, obtaining DME, once an LIP, a licensed independent provider, writes a prescription for a wheelchair, whatever it is, that engenders a ton of paperwork and follow-up. Because typically insurances don't want to pay for stuff, right? And wheelchairs can be very expensive. So typically the company will have to submit like a whole very, very detailed report on all the features of the chair, why they're needed, why they're medically indicated. The insurance will usually deny it the first time. You have to do an appeal, et cetera, et cetera. As someone who does consults here, right, I see kids in the hospital, but I'm probably never going to see them again. If I write that prescription for the next 6 to 12 months, I'm still getting paperwork about that. Which is not always appropriate. If I haven't seen the kid in a year, it's hard for me to justify, yes, like this is still indicated, right? So really, DME prescriptions should really be coming from whoever is following that patient long-term as an outpatient. And again, just say one more time, nobody in the Rehab department is a certified car seat tech. We cannot help with assessing or obtaining adaptive car seats. In terms of here in the DC area, how do kids actually get equipment? So there's a few different ways. Families can choose to work directly with a vendor, and some of the common vendors you'll hear, National Seating and Mobility, NSM, REP, Rehab Equipment Professionals, New Motion is probably the biggest one, and then Roberts. Kaiser has a specific contract with Roberts, so all the Kaiser kids have to go through there, unfortunately. Working with a vendor is good in some ways because you're sort of cutting out the middleman, and so sometimes maybe move a little bit more efficiently, but again, like I mentioned, insurance has an agenda to not pay for stuff. So if that initial request is denied, the vendor may not have the resources to really fight that. Versus an equipment clinic, I would argue is a better option. Equipment clinics have whole teams of people who like write LMNs and do appeals and like help get coverage for things. The other benefit of going to an equipment clinic is you're seen simultaneously by either a PT and OT with the vendor, and so you're really getting like what's most appropriate. You know, the vendor maybe has an agenda to upsell you a little bit and get you like more expensive features on a chair that you don't need. Versus, again, working in an equipment clinic with a therapist maybe kind of reels that in a little bit, in my experience. The big equipment clinics in this area, HSC, of course, has one down the street. National Rehab Hospital has one as well. And in Northern Virginia, Innova Mount Vernon has an equipment clinic. As I mentioned, there are loaner closets for folks who are uninsured, underinsured. The two big ones are Equipment Connections, which is actually run by one of our PTs, and Lollipop Kids. Braces, so an orthosis is the technical term for a brace. An orthosis is any device that's externally applied to the body to improve alignment or function of that limb, is a quick way to think about it. Orthoses are typically named to the body part they cover. So for example, if you're wearing something around your ankle and foot to keep your ankle in a good position, that's an AFO, ankle foot orthosis. If it's going over your hand and your wrist to keep your wrist in a good position, that's a wrist hand orthosis, WHO. If it's going over your trunk to keep your spine aligned in a good position, that's a TLSO, thoracolumbar sacral orthosis. Again, they're usually named pretty simply, just for the body part. Versus a prosthesis is an artificial device which replaces part of a human body, right? So orthosis supports the part of the human body, the prosthesis replaces it. So for example, if you're someone with a below knee amputation, you'll have a prosthetic leg and foot to make up that body part that's lost. Prostheses attached to a residual limb, we don't use the term stump, that's not an appropriate term to use. Residual limb is the better term. Children's does not have its own P&O team. There is no one employed by Children's who makes braces for kids. So if we have an acute need for a brace, so for example, one of Dr. Maceros' kids is in the PICU and they're status post a craniectomy, right? They have part of their skull removed and you need a helmet on them in order to safely get them out of bed. Or if it's somebody who has an unstable spine, but for whatever reason is not a surgical candidate and you need a way to stabilize their spine. So again, like kids in the PICU, typically the case manager in the PICU will call our friends at Hanger. So on the same campus is where NRH is. So you guys probably know this already, but we're here at the Children's Hospital, of course. The next building over is Washington Hospital Center, and the next building after that is National Rehab Hospital, NRH. So it's like a 10-minute walk from where we are, two parking lots. So inside of NRH, there's a hangar on the first floor, a hangar clinic. And so again, the case manager will call, basically ask a favor. The hangar guys will walk over here, cross two parking lots and see that child and pick you and get them what they need urgently. The orthopedic surgery department here has particular relationships with certain orthotists in the area, particularly Biolab in Boston, where certain days of the week they're down in orthopedics clinics seeing patients with the surgeons and doing bracing for them. And then outside of Hanger, Biolab, Boston, the other one you'll hear a lot is Medical Center Orthotics and Prosthetics. A lot of folks both in PM&R and ortho work with that group, and they're really great. As I mentioned, we don't have our own P&O team. Is that a bad thing? Maybe yes, maybe no. One thing to think about is typically insurance will only pay for one orthosis per year. So you want to make sure when you're getting that kid a brace for their ankle, their hand, whatever, that it's going to meet their needs, not just today, but for the next year, because you're sort of locked in with that brace that you choose. As you guys are well aware, after trauma in those first few days and weeks, there's a lot of changes going on. So first off, there's particularly, usually pretty profound swelling in the beginning, depending on what the injury is. And that's why it's going to go away over a matter of days to weeks. So if you get them to some like nice custom fancy brace, on post-injury day 3, by post-injury day 10, it's not going to fit them anymore, right? It's going to be too big. The second thing is that function is changing, right? What they're physically able to do with that arm or leg on post-injury day 3 is very different than post-injury day 10 and very different than post-injury day 28, right? So, it's sometimes a better option if we think that kid is headed to inpatient rehab, let them get the brace there, right? Let the swelling resolve, let them functionally improve before you like go all out and get insurance up there to make them a brace. A better option would be do something temporary, like a focused rigidity cast. You guys have probably seen these before, right? They're usually very brightly colored. We have like bright pink, like bright green. They're made out of the exact same material as if you broke your arm or leg, right? It's like the same cast material. But on like a typical cast for a broken limb, these are bivalves, right? They're open on the top so that you can like get them on and off the patient. You can take them on and off when you need to, and they're held in place with Velcro straps. These are not very durable, right? Especially like this. If you're using an FRC as a makeshift AFO, like a temporary AFO, so you get a patient up in a cast shoe or even just a grippy sock and you get them up and walking on this one to practice walking, after a couple of weeks, you're going to wear this out, right? This is not really meant for long-term weight bearing in, but that's okay, because after a couple of weeks, they're going to be in rehab and we'll get them a nicer brace, right? So it's a nice kind of temporary solution. These FRCs are great. FRCs can be used for function as well as just for alignment. If you have a kid that you're worried their ankles are getting tight, their wrist is getting tight, again, PTRC can fabricate these and they'll have, the sign up in the room, bars on, bars off, right? Like just stretching that limb out, getting the alignment in a good position. Okay, so kids in the hospital, they're clinically stable or becoming stable, and we need to figure out where they're going to go from here. PM&R, PT, OT, and speech can all give recommendations for what level of post-hospital care is needed. And generally we think about inpatient versus outpatient, right? So outpatient rehab means the kid is good enough to go home, families had appropriate training that they can safely manage this child at home, and they're going to go, to a specialized center maybe a couple times a week for PT, OT, speech, whatever kind of therapy services they need. In order to know that, are they good enough to go home? First off, you really have to know what their premorbid function is. You have to know what their home setup is. As a routine part of my encounters, I'm asking families, how many stairs in your home? Like, how do you enter your home? What does the bathtub look like? Is it a shower stall or a bathtub, right? Really getting a sense of what their home environment looks like to sort of think about, can the child function in that environment? What sort of social support do they have? If it's a single parent home and this kid has a cervical collar on and it takes 2 adults to change that seat collar, maybe going home isn't the best choice, right? As well as the extent of their impairments, of course. I really want to emphasize that concept of knowing their premorbid function, because what justifies going to inpatient rehab is a change in function. So again, I used that example earlier of like a 15-year-old with severe spastic quad TP who's dependent at baseline for positioning, mobility, all self-care. Now they're status post their spinal fusion surgery for their scoliosis. Do they have a change in their function? No, right? They were dependent before, they're dependent now. That doesn't justify going to inpatient rehab. So again, you really have to have a change in function to justify inpatient. Once you've made the decision that they can't go home, now you need to think about what level of inpatient placement is appropriate. And so we're going to talk about this concept of acute versus subacute. These words have like very specific meaning, and I think they're not always recognized by primary teams, what the difference is, so we'll talk about that. But the big thing I want to emphasize, if you're recommending inpatient rehab, that child has to have goals, right? Again, rehab is always about what goal are we working towards, right? Because we design our interventions based on what we're trying to accomplish. Rehab is not babysitting. I cannot say that enough. Rehab is not babysitting. You have to have a functional goal you're trying to accomplish in a reasonable time frame to justify going to inpatient rehab. So inpatient rehab is a model of care. It's not just placement. Acute inpatient rehab, by definition, means that child or adults, adults go to rehab too, is in the gym a minimum of 3 hours a day, 5 days a week. That's 15 hours of therapy per week. That is our most intensive option. Can you imagine if I put you in the gym 3 hours a day, 5 days a week, right? That's a lot, that's a lot. To justify or to be appropriate to go to an acute inpatient rehab unit, you have to be medically stable. And maybe that seems obvious, right? You can't be in the gym 3 hours a day, 5 days a week if we're worried about, your labs or this, your monitoring, like that doesn't make sense, right? So we need to have patients who are free of medical devices, right? So if they're on G-tube feedings, it needs to be condensed. You cannot be on continuous G-tube feeds up in the gym moving, right? So condensed G-tube feeds, not on IV meds. We will take folks who need IV antibiotics, like IV antimicrobials, but that's it. That's the only kind of IV you can be on. If you need continuous IV fluids, you are not appropriate for acute inpatient rehab. And again, they can't be on continuous monitoring. If you're that worried about their cardiorespiratory status, they are not appropriate for inpatient rehab. And I think, again, maybe that all seems obvious, but I think it's worth saying because, teams here, when you read primary teams notes, like hospital team or trauma team, they typically at the bottom of the note have their discharge criteria, right? So stable labs, not losing weight, things like that. That all needs to be figured out before you come to rehab. Those are not rehab goals, those are medical goals, right? To come to acute inpatient rehab, you have to have appropriate weight bearing and range of motion precautions. Someone who is non-weight bearing to both legs, what are we doing for 3 hours a day, 5 days a week? If you can't stand, if you can't put your feet on the ground, what are you asking your physical therapist to do for 3 hours a day, 5 days a week? That just does not work for acute inpatient rehab. So they have to have appropriate range of motion and weight bearing precautions. You have to have feasible goals with the expectation of making weekly progress. The way things work in an acute inpatient rehab unit, every week, the whole team gets together and sits down and has a conference where we talk about that person in depth. What are the goals? What are we working towards? What's going on this week? If they're not making goals on a week-to-week basis, they're out. We can't justify keeping them, right? Everybody has a bad day now and then. We're not going to hold one bad day against someone. They didn't sleep well, they're in pain. It's okay to have one bad day, but on a week-to-week basis, you have to be making progress moving forward or we're discharging you to home. So for kids who, have unfortunately have new profound disability that they are not expected to make progress, acute inpatient rehab is not appropriate. And again, that comes where it really comes back to knowing your diagnosis and your prognosis. Some conditions get better and some don't, right? And as a rehab doc, having that knowledge, that background helps you make an appropriate plan of care. Subacute rehab is anywhere between 1 to 15 hours of therapy per week. So it's much more gentle, right? They're not required. Again, I cannot emphasize enough. In an acute inpatient rehab, if it is not documented that you received 3 hours of therapy that day, we are at risk of a denial from the insurance and we will not get paid for that stay. So we literally document to the minute how many minutes of therapy they received in a day. Subacute does not have those same rules. Anywhere between 1 to 15 hours per week is considered subacute rehab. And so this is a better setting for folks who are more medically fragile. For example, an oncology patient who maybe can't tolerate being up in the gym 3 hours a day, 5 days a week. Not to say that we don't take oncology patients. There are certainly oncology patients who are appropriate for acute rehab, but just to kind of give you that mental picture. A more medically fragile patient might be better at subacute. Subacute is also for folks with more modest rehab goals, either because of their disease, their premorbid status, or activity restrictions. So again, that kiddo who's non-weight bearing on both legs, again, you don't have enough to justify 3 hours a day, but could you just justify 1 hour therapy a week? Yeah, just to work on what's an appropriate transfer skill for them. Sure, that's more appropriate for subacute. In addition to subacute rehab, there's also subacute medical placement. So for a child who exclusively has medical goals, so for example, your kid with osteomyelitis who needs 6 weeks of IV antibiotics that mom and dad can't manage at home for whatever reason, let them hang out in a subacute medical placement and get their IV antibiotics, right? There's not a rehab skill you're working towards, a functional skill you're working towards. So your kid who needs babysitting goes to medical, in other words. Specifically here in DC, I just want to review this. There are a ton of adult rehab options. If anybody in this room, God forbid, had trauma, injury, illness with new impairments, disability, you have a lot of choices open to you. But pediatric inpatient rehab is incredibly specialized, and there's just not a lot of places. That's true across the whole country. So here in DC, there's 2 options. The National Rehabilitation Hospital, again, where I work, is exclusively acute inpatient rehab. If you are admitted to NRH, by definition, you are in the gym 3 hours a day, 5 days a week at minimum, right? That's all we do is acute rehab. HOC, I'm sure you guys are familiar with because we end up sending a lot of kids there. But I think it's important to recognize, especially if you've only ever worked in DC, HOC has a completely unique way that they are licensed to the Department of Health. They are not a typical rehab setting. What I mean by that is HOC wears a lot of different hats. So they have some patients they consider acute rehab, who are getting that 3 hours a day, 5 days a week, some that are subacute rehab, some that are subacute medical, some that are long-term care, right? There are kids who just live at HOC who are never going to be appropriate to return to home. They just live there, right? That's not rehab. Long-term care and rehab are opposite mental models and models of care. And then HSC also has their butterfly service, their palliative care service, right? So again, it's a very, very different approach to patient care there, right? Someone who is palliative care, that's literally the opposite of rehab, right? Like you're just focusing on comfort. You're not, rehab is not comfortable. I always joke with my kids that PT means pain and torture. Like get in the gym, right? It's a very different approach. Once we leave DC, up in the Baltimore area, Kennedy Krieger, you guys may have heard of. They have a nationally renowned reputation they're definitely a leader within the pediatric rehab world. They're affiliated with Johns Hopkins. And Mount Washington is the other kind of, they do both acute and subacute rehab in Baltimore. Once you leave DC and Baltimore, now we don't have a lot of choices. In the entire state of Virginia, the entire Commonwealth, there's only one pediatric inpatient rehab unit. It's all the way down in Norfolk, all the way down in Southern Virginia. It's called Children's Hospitals of the King's Daughters. Again, it's the only one in rehab, so, in Virginia. I think my Fairfax families, my Northern Virginia families are always stunned to learn that Northern Virginia is a desert for inpatient rehab. There's just nothing there, so all the way down south. I did want to take a second to highlight the difference between NRH and HSC. At NRH, I mentioned if you're a patient at NRH, by definition, you're getting 3 hours a day, 5 days a week up in the gym. And all of the doctors who work at NRH are PM&R docs, just like me, right? That is their background, their training, their residency trained, they're board certified in rehab medicine. That's all they do. There are no hospitalists at NRH, right? NRH, because of that level of training their physicians have, they have a dedicated spinal cord injury unit. Cindy very kindly referenced the talk I gave for the trauma folks last month, and it was about pediatric spinal cord injury rehabilitation. Spinal cord rehab is its own unique special thing, okay? For folks like me, rehab docs who want to just do spinal cord injury, that's a whole year-long fellowship after your residency training. I just can't emphasize enough. It's very, very specialized. Any child in the DMV area who is unlucky enough to have a spinal cord injury really deserves to be at a place like NRH or KKI, acute rehab, right, where you have dedicated spinal cord injury specialists. NRH also has a dedicated traumatic brain injury unit. NRH does not have respiratory therapists, so we will not accept patients on a vent. We will accept folks with trachs, because typically the most common reason I'm seeing a patient with a trach is because they had a traumatic brain injury and they couldn't breathe, they couldn't ventilate themselves. And as they recover from that TBI, we can decannulate them. So I've decannulated trach patients before at NRH. We have a great system for doing that. We also do not accept patients on TPN. Again, if you're on TPN, you're probably not good enough to be in the gym 3 hours a day. And the way that we're licensed by the Department of Health is to take kids ages 3 to 18. So when we do want to take a 2-year-old, which we certainly have done before, we need to apply for an exemption with the Department of Health. HSC, all the docs who work there are pediatricians, right? So very different, skill set, different background, different training. They do have respiratory therapists, so they will accept vented patients, as I'm sure you guys know, but they do not have sitters, right? So for folks who have a TBI, who are in that stage of being very confused and agitated, may not be the most appropriate place. Most of those kids need a sitter, right? Whereas NRH will do sitters. We're going to move on and talk about pediatric traumatic brain injury at this point. I think Dr. Maceros, very hard to follow Dr. Maceros. He does such a good job reviewing TBI, but we'll talk about it from a rehab perspective. So I know he gave you that statistic about the number of kids with a TBI. Another way to think about it is that 51,000 kids with a pediatric TBI require hospitalization. So again, that's a severe injury, moderate to severe injury, because as Dr. Maceros said, your kids with a very mild, the soccer player who got dinged in the head, they're not getting hospitalized, right? But they had a concussion, they had a mild TBI. Of that 51,000, 10% of those will be hospitalized for more than 10 days. So again, speaks to the severity of what we're talking about here. When we think about who gets a TBI, who are these kids? We see a bimodal distribution. So it's our very, very young kids, our toddlers, our infants and toddlers, and then our teenagers, our 15 to 17-year-olds. So it's like, if you're graphing it, it's like a camel, right? It's like this bi-hump. The highest incidence and greatest morbidity and mortality is in our teenagers, our 15 to 17-year-olds. Mostly boys, right? 60 to 40% boys to girls. And when we think about risk factors, we know that a pre-morbid diagnosis of ADHD, those kids are more likely to have a TBI, probably because they're engaging in reckless behaviors. So overall prevalence among all kids of ADHD is 6%, but among kids with a TBI, 10 to 20% had a pre-injury diagnosis of ADHD. So definitely a serious risk factor. What causes these brain injuries in kids? Motor vehicle accidents, just like Dr. Maceros said, especially in the teenagers. That's the most common reason. And for our little ones, falls. So in 1 to 4-year-olds, it's like the falls. NAT, I think Dr. Maceros did a great job reviewing non-accidental trauma, so we won't spend a ton of time on this. But I just wanted to highlight that even though NAT is a relatively smaller proportion of brain injuries in our kids, in both infants and our toddlers, it causes a disproportionate percentage of severe injuries. In other words, if that baby or toddler is coming in with an NAT, it's not going to be good. They're going to have a severe injury. They are not going to have good outcomes, generally speaking. It's very, very sad. That triad that we look for, that clinical triad of the subdural hemorrhages, the retinal hemorrhages, and the change in behavior and mental status, right, the encephalopathy. And typically the history is incompatible with the severity of injuries, right? So the caregiver is like, oh yeah, they fell out of their high chair. Meanwhile, they have half a dozen fractures in different stages of healing. They have like this, awful subdural. It just doesn't make sense, right? So, associated injuries, as you can imagine, whatever that force was that was big enough to injure their brain probably injured other parts of their bodies too, right? So about 50% of kids with a TBI have other injuries. If the TBI is associated with chest and abdominal injuries, decreased survival is, obviously you can imagine. This last statistic definitely keeps me up at night. In one study, undetected fractures during acute care were found in 16 out of 60 kids. So not a small percentage, right, that we missed fractures, that we didn't find them. So I will say when a kid with a traumatic brain injury comes to NRH and, if they're having really bad storming, really bad dysautonomia that we can't get under control, or they just look uncomfortable, just do a skeletal survey, right? Just don't miss the fracture. On exam, sometimes what I'll do is I'll just take my hands and I'll literally walk along their long bones, just every centimeter or so squeezing, and I'm watching their face, I'm watching the monitor to see if we're getting changes that indicate that there's a focal source of pain. Just image them. We miss fractures all the time in brain injury kids. Just want to take a second to highlight this concept of a primary versus secondary injury. So the primary injury is the force itself. Whatever that force was that caused a mechanical disruption of our membranes and our axons. And as Dr. Maceras talked about, you can see these contusions typically on the surface of the brain, this kind of a focal gray matter injury. And then from the deceleration or rotational forces, right, it's like boom, boom, or the rotation, you get these shearing injuries. So the term for that is a diffuse white matter injury. On a radiology report, you'll see that as a diffuse axonal injury, DAI. That is bad. When that happens, that's a bad thing. Kids, like Dr. Maceras said, have relatively larger heads, weaker neck muscles, higher brain water content compared to fat, right? They're less myelinated. So all of those reasons that the effects of the force is sort of amplified, if you will. So you have a kid and their caregiver, they're adults. They were in the same car, right, going the same speed, but the parent looks okay and the kid has a severe traumatic brain injury, right? You do see that discrepancy at times. The secondary injury are all the metabolic and hemodynamic changes that happen because of the primary injury, right? So typically what we worry about is that high ICP. Because the higher your ICP goes, the lower your cerebral perfusion pressure, right? You're not getting blood to your brain if ICP is too high. I know Dr. Maceras reviewed this, so I'll just quickly go through it too. So there's a few different ways we can talk about to determine severity of the injury. The GCS, like Dr. Maceras said, is the one everybody goes to. And there's sort of 3 domains we're looking at. I call the domains eyes, words, and moving, because the number of letters in each of those words tells you how many points you can get. So in eyes, there's 4 letters in eyes, you can get 4 points. Words has 5 letters, you can get 5 points, and moving has 6 letters there. I did want to just highlight for moving, I know Dr. Maceras mentioned this, but so 1 is you're not moving. 2 is what we call decerebrate posturing, right? That's where your shoulders go into internal rotation and your elbows go into extension, right? This is what decerebrate looks like. Decerebrate is really bad. So again, it has a lot of letter E's in it, so you can remember it for extension. And a little bit of dark humor, you're extending to heaven because it's bad, right? That's a low score, so that's a 2. Decorticate posturing, core is like the Latin word for heart, right? So you're bringing your arms up this way over your core. That's a grade 3 on the motor scale. 4 and 5 are responses to pain. So a very localized response. If I pinch you and you just move your hand out of the way, that's a very localized response. That's a 5. Versus if I pinch your nail bed and you move your whole hemi body or your whole arm, that's a generalized response. That'd be a 4. And then 6, of course, is moving to command. As Dr. Maceras said, I just want to highlight it again, the motor score at 72 hours post-injury is most predictive of long-term disability. Another scale you can use to help you determine severity of a brain injury is the duration of post-traumatic amnesia. So after a trauma, right, when our brain experiences trauma, we lose the ability to lay down new memories. So long-term memories, biographical information, what's your name? What was your dog's name when you were a kid? What address do you live at? That's some deeply ingrained stuff. Kids will remember that. But what did you have for breakfast this morning? They don't know, right? They can't lay down new memories. And the duration of PTA is directly correlated with severity of injury. So under an hour, we consider that mild. Up to a day is moderate. More than a day is severe. There is a test we use called the Children's Orientation Amnesia Scale, the COAT. If you get a 78% on 2 consecutive days, you're considered out of PTA. And then the third one I want to mention for determining severity is duration of unconsciousness. The definition of consciousness is the ability to respond to your environment in an adaptive, meaningful way. So just to give a few examples of that, functional object use is a really great way to demonstrate consciousness. So if I put a toothbrush in your hand and you start to brush your teeth, you mimic brushing your teeth, you're showing me you know what that object means. That's an adaptive response. So if I put a comb in your hair and you do that, if I give you a ball and you throw the ball at me, right, you're showing me that you know what that object does. That's that's a sign of consciousness. I think what gets really tricky, I did my residency in a place that had a specialized rehab program for folks who are in a state of unconsciousness. So we're trying to wake them up. We're trying to get them to emerge from their disorder of consciousness. What gets really tricky is something like crying, right? So the family will tell you, I showed him a picture of, his aunt who died last year and he started crying, so I know he's conscious. Well, maybe he got a piece of dust in his eye and that's why he cried, right? Like that's hard to prove consciousness with something like that, because that could be, because tears are reflexive too, right? So that's a little tricky. Disorders of consciousness includes a state of being in a coma, right? So a coma looks like you're just sleeping 24/7. Someone who's vegetative, that's someone who has defined sleep-wake cycles. Like you walk in the room, their eyes are open, they're awake, but they're not interacting with their environment in a meaningful, adaptive way. And then minimally conscious is they're like showing you glimmers of consciousness, but they haven't fully emerged yet. They're not consistently interacting with you in a meaningful way. Less than 15 minutes mild, up to a day moderate. A day to 3 months is severe, and more than 3 months is profound. The last scale I'm going to talk about, and again, this is one that might be new for you guys, the Rancho Los Amigos scale. Rancho Los Amigos is a really well-known rehab facility out in California that, has treated a ton of TBI patients, and sort of from essentially natural history, they've put together this scale that helps you sort of understand what recovery and traumatic brain injury looks like. So initially when the scale was devised, it was 8 points. They've since modified it to be 10 points, but we're just going to talk about the first 8 because that's what's the most relevant. Level 1, 2, and 3 are all types of a response you're looking for. So level 1 is no response, in other words, coma, right? Folks who are in level 1 are in a state of unconsciousness. Level 2 and level 3 is where we start to have a response to our environment. Level 2s are the very generalized responses, right? So, occasionally if there's like a noise in the room or something, they'll kind of react to it, but it's like very, very minimal, very generalized responses. It's not like specific or purposeful or localized. Level 3, now we're starting to show some localized responses, right? So if when the door closes, they don't just startle, they actually look towards the door, right? Like they're trying to figure out, like paying more attention to their environment, but still like very much out of it. At this level, again, to be in a rehab facility at this level, it has to be a very specialized coma stim program. But you certainly see those folks in the ICU. That's really an ICU setting. Level 4, 5, and 6 is now we're getting appropriate for rehab. And these are the folks that you see up on the 5th floor all the time. So our level 4s, that's our confused and agitated. Those are the kids who are in restraints because they're wild. They're throwing punches. They don't know what's going on. They're angry. They're agitated. They're worked up. So again, they typically are in restraints as your level 4s. And again, we certainly see those folks up on the 5th floor. Level 5 is now we're out of that agitation stage. We're not throwing punches. We're not angry anymore, but we're still confused as all get out, right? They don't know what's going on, but they're very inappropriate. So these are the kids who are constantly need redirection. They're trying to get up out of bed. They're trying to go into other people's rooms. They're just like a little wild, but they're not angry and agitated. So your level 5s, those are the folks on sitters. So again, if you're in a rehab facility accepting patients at a Rancho level 5, you have to have sitters to really manage those patients appropriately. One way to remember level 5, there's 5 fingers, on your hand. So it's like, stop, stop, stop. Like as the nurse, as the caregiver, as the staff, you're constantly like, stop, stop, stop. You're constantly trying to redirect that patient. That's the way to remember it's level 5. Level 6, we're still confused, right? Johnny, what's going on today? I don't know. Why are you here? I don't know. They don't know what's going on, but they're appropriate, right? They're no longer acting wild. They don't need a sitter anymore. They're appropriate, but they're just still very confused. And they still need a lot of help with, as you can imagine, someone in a level 6 is not really doing their ADLs appropriately, right? Those executive function skills are not there yet. Level 7 and 8, now we're getting closer to being able to go home and do outpatient services. At level 8, we're automatic and appropriate. So again, we're no longer confused, right? We know who we are, where we are, why we're there. That's great. We're kind of oriented. We're acting appropriately. Again, we're not throwing punches. We're not screaming. We're not agitated. So that's great. But we're very automatic. So if you give us a very simple task, like, put all these seeds in this jar, right? Something like very easy, they can do it. But if you introduce a new variable, or you kind of make it a more higher level skill, we start to fall apart. So we still need a lot of support to be successful in our day-to-day life. But again, essentially good enough to be home with our family at this point. And then level 8, now we're appropriate and purposeful. So again, they can handle new variables. They can handle more higher level tasks. But they still need maybe a little bit of standby assistance just to make sure that, things are going okay. I could easily do a whole hour-long talk about rehab issues, what we see with our pediatric traumatic brain injury patients when they're in the rehab unit. But very quickly, the rehab doc, we're managing agitation, dysautonomia. Again, these kids can have all kinds of vital sign instability. Impaired arousal and attention. Again, we're trying to get them to be awake and interacting with us. Sleep is so important for rehab. If you do not have a patient who's sleeping at night, you are not going to accomplish anything. You're not going to meet any of your goals. As you guys probably know, here in our PICU a couple of years ago, we put together this committee, the Early Mobility and the ICU Committee, and because, that's a big buzzword in the medical literature. As you guys probably know, early mobility, we're all about that. It was really illuminating when folks on the rehab team, myself, the PTs, OTs, we sat down with the ICU folks just to sort of talk about how is this going to work, what are we going to do. It was astonishing to see how much sleep was not valued in the PICU, which of course it's not. These patients are critically ill. You're just trying to keep them alive. I totally get that. But for example, because the daytime nursing staff had so many tasks on their list, bathing the patient was a 3 a.m. task. That was done by the night shift. If you're bathing your patients at 3 in the morning, they're not sleeping and they're not going to do well the next day, right? So really valuing sleep is such a huge, huge, huge part of rehab, making sure that we have uninterrupted care at night, let these kids get good sleep. Tone, again, managing muscle tone is a huge part of what rehab docs do, because kids who are very, very spastic, very hypertonic, they cannot use their limbs in a functional way, right? And then lastly, managing GI, bowel, bladder. Rehab docs are obsessed with pooping. We always want our patients to be having regular bowel movements. If you're constipated, you're not going to be up in the gym 3 hours a day, 5 days a week. You're not going to want to move, right? So making sure bowel and bladder, especially neurogenic bowel and bladder management, is a huge part of what we do. I just did want to spend one slide talking about agitation, because I know this is, in the acute care level, this is definitely something you guys deal with, right? Patients who are really agitated after a brain injury. So agitation can include aggression, right? The kids who are throwing punches at you, who are violent. Disinhibition, right? So anything that occurs to them, it's going to happen, right? So sometimes it's very funny. They say things that are very offensive and very funny. But just, whatever they think they're going to, whatever they think of, they're going to do it, right? They're going to just act out. Akathisia is an internal sense of restlessness. These are the kids who just kind of can't stop moving. They just don't look comfortable in the bed. Emotional lability, right? These kids are cool and calm 1 second, raging the next, laughing the next, crying the next. They just cannot regulate their emotional output. They're just kind of all over the place. We see these issues more commonly in frontotemporal lesions. Your frontal lobes is your personality. It's your behavior, right? So when our frontal lobes are impacted because of a car accident, whatever it was, that's when you're going to see these sort of issues. We always want to start with behavioral and environmental modifications before we jump to drugs. One phrase you certainly hear a lot in the rehab world is a low stim environment, right? So someone with a severe brain injury, they should not be in one of the quad rooms in the PICU, right? That's a disaster because there's constant lights, constant beeping, constant noise. It's just going to ramp everybody up. So a nice private room, lights down low, don't leave the TVs blaring for no reason, right? TVs off. If someone's having a conversation, there's just one conversation at a time. There should not be a million visitors in that room, right? We're trying to keep things nice and cool and calm, right? Literally put a fan on. If it's hot in the room, get a fan, cool it down, just make it a nice, calm environment. When we do want to use meds, propranolol is always our go-to, right? Rehab docs love propranolol. It is the best studied drug for managing post-TBI agitation. It's a beta blocker, as you guys know. As opposed to our other beta blockers, propranolol is incredibly lipophilic. It's super fatty, so it crosses the blood-brain barrier. So it works exactly where you need it to by calming down that excitability, right? That sympathetic output, you're calming that down. Clonidine also works centrally, another good choice. Gabapentin, we love gabapentin. You can use anti-seizure meds for managing agitation. I personally don't love that route, but sometimes you can. Antidepressants, so both your SSRIs and TCAs can be helpful here. If we have to jump to antipsychotics, we definitely want to use our atypicals, like Seroquel is a good choice, and you guys, I'm sure, have seen plenty of kids at this hospital on Seroquel. We never want to give Haldol. Haldol is a typical antipsychotic. The way it affects dopamine will hurt neurorecovery. We never give Haldol to brain injured patients. And then benzos, we, as much as we can, we avoid benzos. We know that benzos will delay neurologic recovery, but if you have a patient who's wild and out, they're unsafe for the staff, unsafe for the patient, use the benzos if you have to, right? But we try to avoid it if we can. The last point I want to make before I wrap up is return to school. So much of what we do in pediatric rehabilitation is thinking about return to school planning. How do we get that patient back to school? As you guys probably know, the law of the land is IDEA, the Individuals with Disabilities Education Act. This was passed in 1990 and makes TBI an eligible diagnosis for special ed services for an IEP, an individualized education plan. An IEP is meant to address the child's global functioning, not just academic performance alone. And if a child has an IEP, that makes them eligible for school-based therapy services. So they can get in-school speech therapy, PT, OT, whatever it is, to work on goals related to school achievement. So It is very appropriate to also have outpatient therapy on board too, because they have a different focus of treatment, different goals. But again, you know, kids with TBI go back to school. You want to make sure you're setting them up for success. I know I talked really fast because I felt I got a lot to cover, so I'm sorry if I was talking too fast. Hopefully that worked well.
Before you go, could you give us what your take home is that you would want everybody in this room to, and everybody online, to take home with them to know about rehab?
Call us. Just call us. So speaking for myself as one of the PMR docs, I know Dr. Maceras made a cute little joke how he'll be mad if you call him in the middle of the night. I will never be mad. Like, just call us. We're here to help. Yes, thank you. Exactly. Yeah. And again, PTOs, you know, again, rehab on the one hand, it's a lot of common sense approaches and interventions, but it's also, again, it's its own unique thing that, frankly, in nursing school and medical school, we don't get a ton of training and education about, right? So I don't expect you guys to know, should I be calling PT, OT, speech, should I call PMR? Just call us and ask. We'll tell you what that kid needs. So just call us. We're very friendly.
Not everybody in the room and online would know how to contact you. Could you just go through those steps?
Yes. Well, first off, my name is Melissa Fleming. You can email me. I'm in the system. Fleming, just one M. Our pager number is, the pager is always forwarded to whoever is on call for PMR that day. So it's 50016, how you page us. I'm terrible about using the Zebra phones. I hate carrying a Zebra phone, I'll be honest, because I have to carry my pager as it is. So I'm usually not on the Zebra phones, but you can page me, you can email me. You know, my chief, Dr. Burton, is also, as you guys probably know, incredibly approachable and easy to talk to. Email me and Dr. Burton if you have a question. We will get back to you.
Thank you so much.
Yeah, of course. Thank you so much for the opportunity. I really appreciate talking to you guys. Thank you so much.